So the ABCs of wound care connotates simplicity. And 9 times out of 10, pictures are simple. So this is kind of a pictorial representation of some of the basics of wound management. There my disclosures actually are. So when we look at wound healing and the basics thereof, I think everything starts foundationally upon an accurate diagnosis. Wounds are a finding, but you have to have an accurate diagnosis in order to achieve balance of healing. And that balance occurs by juggling a number of different factors, certainly as reflected in this meeting, optimizing perfusion in a timely fashion, controlling edema, controlling infection, certainly performing appropriate wound debridement, offloading pressure points, accomplishing moisture balance or moist healing, and overall disease management. You can certainly add to this list, by no means is it complete, but ironically, Dr. Carmen and I didn't collaborate on our slides ahead of time, but if you think it's juggling, it is, a lot of factors. So sifting these things out certainly becomes important when it comes to basics. So certainly a basic is that of perfusion. When we look at arterial ischemic ulceration, classically these are full thickness ulcers with a punched out appearance, may or may not have fibrinous or fibronecrotic debris in the base, can oftentimes occur over bony prominences and can be very painful. The obvious caveat there is the diabetic patient with neuropathy, but these are examples of wounds that occurred from ill-fitting shoe gear in the setting of previously undiagnosed arterial disease. So the next question becomes, in terms of things like referring to our vascular colleagues, what about the timing of such? Well, an example here pictorially is a 63-year-old diabetic man who presented with a painful toe blister. Kind of unclear as to the nuts and bolts of how this occurred, duration, onset, those types of things, but he said it hurt, so it prompted a visit. In any case, you can see it has a fairly cyanotic appearance to it, and if we look at non-invasive studies in the proximal aspect of the leg, it doesn't look too bad. As we move down towards the ankle, we get a different sense in a diabetic with calcified vessels, and then we look at distal perfusion in terms of transmetatarsal and digital tracings and digital PPGs. You can see that indicates he probably has some degree of tibial vessel disease, and that's certainly echoed by the toe brachial index of 0.23. So that timing piece becomes critical. So that fairly non-innocuous looking toe, despite multiple attempts to revascularize severe infrapopliteal arterial disease, this gentleman actually develops ischemic rest pain, goes on to an isolated fourth toe amputation, unfortunately though a marked decline in a 4-week period such that he went on to a transtibial amputation. So timing is certainly an issue when it comes to the basics of management. We can't just wound careize patients like this, so that timely referral and follow-up is critically important. Now, what about the opposite end of the spectrum for timing? A 68-year-old diabetic man, multiple comorbid factors including ischemic cardiomyopathy, heart failure, previous MI, AFib, coronary disease, as well as valvular heart disease. But he had tissue loss on his wounds that had been present for many, many months. You can see these fairly well circumscribed defects, but he also had severe chronic pain that previous providers had chalked up to his multifactorial edema. Well, being dutiful, acknowledging risk factors for PAD and the individual features of the wounds, we went ahead and got non-invasive studies, and clearly this gentleman has severe occlusive inflow disease. And when you look at him angiographically, he was reconstructed in the aortoiliac segment with endovascular strategies. And then post-procedurally, you can see now his tracings are markedly improved, and he's actually normalized his ABIs. Now then, we can actually go after that pain and swelling component with appropriate local wound care and debridement. And after a little over 3 months, he has not only complete resolution of that edema, but complete resolution of that pain, again, not chalked up to edema, but ischemic rest pain. So the timing was different here. We had the luxury of time in this situation, but the common thread was that arterial disease. Another aspect of basic of management is that of edema control. And classically, when you think about edema control, we think about venous states and venous disease. And Dr. Kolluri is going to speak to mixed presentations, but the classic venous stasis ulcers is pictured here, and we do things like compression therapy to reduce volume. So a variety of different wraps and stockings, et cetera. And when patients come back, they sometimes complain, but it's desirable to see those skin folds when we reduce that interstitial volume. But it can also be important to recognize edema outside of classic venous disease. So what's pictured here is a 93-year-old gentleman who comes in with tissue loss directly over the medial malleolus, extremely painful, over a bony prominence, history of remote above-knee amputation on the opposite side, has an ulcer present for the better part of 3 months, and unfortunately had been treated with a couple courses of antibiotics and wound careized. But the teaching point here was to really think about risk factors, and certainly everything under the sun points to peripheral arterial occlusive disease, but on exam he had an intact pedal pulse. So one of the most important things, the physical exam is king, and then taking that good history and physical exam to the next level, asking the right questions, you get the answers you seek. Instead of severe occlusive disease, this was simply a matter of a traumatically induced skin ulcer in the setting of uncontrolled dependent edema in a non-ambulator. So with some appropriate local debridement and wound care and elasticated compression and more consistent leg elevation, he had marked improvement in a short period of time. So again, edema control alone can play an important role. Now, another basic is that of infection, and I'm certainly preaching to the choir when we think about patients with wounds and those that take care of them. The classic features as listed with erythema, calor, tissue edema, increased drainage. Pain, again, perhaps not in the diabetic patient, certainly, and then more closely looking, fluctuance in depth. When you take a look at a wound such as this, clearly a fairly unhealthy looking wound with a lot of focal erythema and associated calor. And it's important to remember to look with one's hands, not with just one's eyes. When we probe this wound, there's actually a tract that communicates, and then probing deep actually reveals extension to the level of bone and joint. So unfortunately, this patient doesn't just have superficial wounds. This actually extends to the level of a cuboid with associated osteomyelitis. And another critical component when it comes to infection and infection control are that of cultures. More often than not, those superficial cultures are not going to be reliable identifying true pathogens, so deep tissue cultures, whenever possible, is certainly the gold standard. There's also basics when it comes to infection control with dressings. A lot of dressings are marked that they're good for a certain amount of time, but not to leave those in place for extended periods and to adjust the frequency of change according to the volume of drainage. It sounds trivial, but it's like a kid with a dirty diaper. How often do you change it? As often as needed. The same could be said of wound care. So you can see here a fully dissolved alginate type dressing that had been left in place too long. We didn't change anything other than the frequency instead of every 4 to 5 days, daily. And on first follow-up a couple of weeks later, a markedly looking different wound just by increasing the frequency of dressing change. But we can also take advantage of imaging studies, and certainly we have a wide array of things from plain film radiographs through MRs and CTs to look for the extent of tissue involvement in bone. You can see radiographically a classic example of septic arthritis and osteomyelitis involving the first metatarsal phalangeal joint. And it translates clinically. This was an example of a patient who had non-traumatic partial first ray amputation due to pedal ulceration and osteomyelitis. But it's important to remember sometimes that those clinical signs of infection are muted in diabetics patients, again, in the setting of neuropathy. So you can see a fairly unhealthy looking amputation site initially after it had dishist. So radiographically, though, at least an initial presentation, reasonable appearance to the bone, kind of a nice linear appearance to that residual first metatarsal. But unfortunately, true to form, the patient decided not to come back for follow-up, followed up with his local provider, and came back months later with a chief complaint of having stubbed the second toe. And when asked about that non-healing amputation site, yeah, I've been putting some kind of gel or some such thing on it, and it hurts every now and then. But being dutiful and looking at imaging studies, you can see now radiographically, not only does the patient have evidence of osteomyelitis in the residual first metatarsal, but also in that adjacent second metatarsal phalangeal joint with septic arthritis. So those imaging studies prove very helpful serially, especially in the setting of diabetes with neuropathy. And finally, offloading. As a podiatrist, I'd be remiss if I didn't mention that. Certainly, we podiatrists look at things like structural deficits and abnormal mechanics and the creation of callus, which we may say is pre-ulcerative in nature and leads to that classic neuropathic ulceration, as you can see pictured on the right. But it's also important to remember some of the basics. We can't heal all wounds, and we do things like transmetatarsal amputations, but at the risk of stating the morbidly obvious, don't forget the opposite extremity. An example of a patient who didn't have appropriate fitting shoe gear and then went on to bilateral transmetatarsal amputation. Now, when it comes to specifics of offloading, the time constraints here are inadequate to go over all of them, but some basics. Choice is based largely on ambulatory status and patient function. There are both a wide range of weight-bearing and non-weight-bearing devices, also for short and long-term use. A couple pictured offloading boots in the hospital. Certainly, the total contact cast is often referred to as the gold standard of taking the patient out of the equation with reducing pressure points. And finally, a whole host of orthotics and shoes with various modifications to reduce pressure points. So in conclusion, the ABCs of wound care should include optimizing perfusion in a timely manner, certainly controlling edema, treating infection, and reducing pressure points. Thank you.